Well, hey, everybody, this is Robert, and welcome to Outbreak News This week. And I'm trying to make this a little bit like the old radio show that I ran from 2013 to 2019. And we'll take a look at a bunch of different stories, sometimes related, sometimes not. And just take a look at what's going on around the world in the world of infectious diseases. And I want to, of course, start out and do quite a bit on coronavirus or COVID-19. And it's been some pretty interesting news coming out, and some different actors coming out talking about lockdowns. Lockdowns have been questioned on how effective they are, and a lot of people are saying not very effective at all. And indeed, they cause a lot of collateral damage. And let's go ahead and start with this report out of news.com.au, where they were interviewing David Nabarro from the World Health Organization. So let's see what he has to say.
We had Professor Sunetra Gupta from Oxford University on, and she was implying, and I'm interested in you because you have a global mandate, a global view, was that a problem we don't think about in lockdowns is that they're very nationalistic. That if we lock down our economy, then it hits our economy. But it also means we are not buying stuff. We're not trading with weaker economies. We are not just destroying our own jobs, we're destroying the jobs of all those that in the poorer parts of the world that export to us. That seemed to me to be a reasonable point.
Really important point by Professor Gupta. I want to say it again. We in the World Health Organization do not advocate lockdowns as a primary means of control of this virus. The only time we believe a lockdown is justified is to buy you time to reorganize, regroup, rebalance your resources, protect your health workers who are exhausted. But by and large, we'd rather not do it. Just look at what's happened to the tourism industry, for example, in the Caribbean or in the Pacific, because people aren't taking their holidays. Look what's happened to smallholder farmers all over the world because their markets have got dented. Look what's happening to poverty levels. It seems that we may well have a doubling of world poverty by next year. We may well have at least a doubling of child malnutrition because children are not getting meals at school and their parents in poor families are not able to afford it. This is a terrible, ghastly global catastrophe, actually. And so we really do appeal to all world leaders. Stop using lockdown as your primary control method. Develop better systems for doing it. Work together and learn from each other. But remember, lockdowns just have one consequence that you must never, ever belittle, and that is making poor people an awful lot poorer.
Very interesting, right? I totally agree, and I have agreed for a long time. This is not a new opinion for me. However, it is a new opinion for the World Health Organization because it wasn't that long ago that the Director General was very pro-lockdown and praised the draconian measures that China took when this all started. So this is kind of a backflip on what the World Health Organization was saying not that long ago. But it is a welcome backflip, and I appreciate that. And that really leads into this thing that happened on October 4th, and several infectious disease epidemiologists and public health scientists, several being three, got together and they made this Great Barrington Declaration. And let's take a look at it. And what their concern is a lot what Dr. Nabarro's concern is the collateral damage. Are lockdowns the way to go? The evidence is coming out and it shows that it's not, and it's causing a lot of problems. And these experts are concerned about the damage, the physical damage, the mental damage from these current COVID policies. And they're recommending an approach called focus protection. And they do kind of look at herd immunity. And they say, as immunity builds in a population, the risk of infection to all, including the vulnerable, falls. We know that all populations will eventually reach herd immunity. Example, the point at which the rate of new infections is stable. And that this can be assisted by, but is not dependent upon, a vaccine. Our goal should therefore be to minimize mortality and social harm until we reach herd immunity. And they're saying we should adopt measures to protect the vulnerable. And this should be the central aim of public health responses. In other words, stopping the virus is not this monolithic thing. Public health is much wider than that. And you need to look at all these other areas where people are not getting health care for other issues, cancer screenings. You have an increase in suicides. You have depression, children not going to school, which is nonsensical in many ways. All kinds of collateral damage that's going on because of some of these policies. The Great Barrington Project is saying we need to turn away from these methods that have been used, very monolithic type methods. And they give an example. By way of an example, nursing homes should use staff with acquired immunity and perform frequent PCR testing of other staff and all visitors. Staff rotation should be minimized. Retired people living at home should have groceries or other essentials delivered to their home. When possible, they should meet family members outside rather than inside. A comprehensive and detailed list of measures, including approaches to multi-generational households, can be implemented and is well within the scope and capability of public health professionals. But those that are not vulnerable, right, people 30, 40 years old and younger, they should be allowed to resume life as normal. Simple hygiene measures such as hand washing and staying home when sick should be practiced by everyone to reduce the herd immunity threshold. Schools and universities should be open for in-person teaching. Extracurricular activities such as sports should be resumed. Young, low-risk adults should work normally rather than from home. Restaurants and other businesses should be open. Arts, music, sport, and other cultural activities should resume. People who are more at risk may participate if they wish, while society as a whole enjoys the protection conferred upon the vulnerable by those who have built up herd immunity. And this happened October 4th in Great Barrington. And the three founders are Dr. Martin Kulldorff, he's from Harvard, Dr. Sunetra Gupta from Oxford, which she was mentioned by Dr. Nabarro in his interview on Australian media, and Dr. J. Bhattacharya. Hopefully I said that correct. He's another physician epidemiologist from Stanford. And there's a number of people that are co-signing. So it's a very interesting thing. I wish it came out earlier, because definitely this focused protection approach is much more viable than a lockdown approach that is very, very destructive to economy and health in many other ways. So I encourage you to check them out. The Great Barrington Declaration. You can just Google it and you can check it out for yourself. And here's an article concerning lockdowns in Africa. And it says that could spell devastating poverty, hunger, and unemployment. There is relatively low fatality rate from COVID-19 on the continent, and that's likely due to its very young population. So let's take a look at what they say. And I'm going to go down here to, because you really can't compare Africa, for example, to places with a higher median age, older population, like many of the countries in Europe. And it says here, and is this really the best way to handle this new disease? Speaking of lockdowns, especially when experts say we may have no return to normality for several years. Certainly the debate over how to balance control of a deadly virus with wider health, economic, and social concerns is magnified many times over in places that have very few safety nets, far poorer people, and much deeper problems. Health budgets, often already inadequate, were blown on fighting COVID-19 as priorities were switched from more serious diseases in Africa, such as malaria and tuberculosis. Now reports show the horrific collateral damage. One study said suspending distribution of insecticide-treated bed nets and falling use of drugs could lead to malaria death rates not seen for 2 decades. Another warned that interrupting programs to dole out deworming medicines will worsen the impact of malnutrition. Others highlight surging levels of infant and maternal mortality, with 1.16 million extra child deaths in one worst-case scenario for the continent, plus hundreds of thousands of more deaths from TB and AIDS-related illnesses. The economic impact, intensified by global economic downturn, is equally terrifying, with talk of poverty rates set back decades. One report suggests that almost 10% of Africans might slide into extreme poverty, with 2/3 of this blamed on the lockdown. The UN calls this a global humanitarian catastrophe, as it warns an extra 130 million people could be pushed to the brink of starvation this year. So will this be the biggest tragedy of the pandemic? How the rush to lockdown unleashed an epic man-made disaster that led millions to death, led to millions of needless deaths? Great question. And we're starting to see things kind of pan out that way, and it's caused a lot of damage. So I don't know. What do you think about the lockdowns? Good idea? Or do you think the Great Barrington Declaration is the way to go? The World Health Organization is agreeing with them. The author of this article from this British paper is agreeing with them. Lockdowns have been catastrophic, and there's a lot of collateral damage. Okay, let's go ahead and switch gears. We're still going to talk COVID, but I want to take a look at some of the numbers. Okay, so here's our global cases, 37.5 million. But the one I want to take a look at, you still see that the United States is the highest, followed by India. Now, India did cross the 7 million mark a couple days ago. And I suspect that they're going to surpass the United States within a week or two or so. But we'll see. I could be wrong on that. And the death toll, this is the interesting part. In the United States, going on 7.8 million cases. They have 214,000 deaths. India has 7.1 million cases and half the fatalities. So what's going on there? That's a question that a lot of people have been asking for months now. And this Times of India report takes a little bit closer look in the mystery of India's low coronavirus death rate. And it says India, with its population of 1.3 billion people, has the world's second highest number of coronavirus cases, now more than 7 million, but far fewer reported deaths than other badly hit countries. The figures have baffled experts, with explanations ranging from the young population to immunity given by other endemic viral diseases and underreporting. All right, let me get rid of this stuff here. Okay, it says the world's second most populous nation has the lowest number of deaths per 100 confirmed cases. The observed case fatality ratio among the top 20 worst affected nations is at 1.5%, according to Johns Hopkins. And this is lower than Mexico, the UK, France, Iran, Indonesia, the US at 2.8. and so on and so forth. Mexico has over 10% case fatality rate, the highest. It says that older people suffering from conditions such as diabetes and heart disease have become a particular target of the pandemic, but India has a young population with a median age of 28.4. And that's still 10 years higher than the median age in Africa, which is somewhere around 18, which is also seeing very low death rates. Now they go ahead and compare it to France, which has about a tenth of the cases, 700,000 cases, and 32,000 deaths, with a death rate of 4.7. Their median age is 42.3, so a significantly higher older population. Now they say that the epidemic that was already raging through Europe, particularly Italy and some of the other European countries early on, first kind of gave India a precursor of what was to come. It gave them time to prepare. Prime Minister Modi did order a lockdown, which severely limited movement, and that went on for some time. And they suggest that the lockdown may have helped doctors learn from the experiences of other countries. It says, many of the treatment protocols were much better stabilized, whether it be oxygen use or ICU care, according to experts in India. So a lot of this stuff was already established in Europe. India observed it. And then when it really started taking off in India, they already had some of these capabilities. They also suggest that there's several experts, including virologist T. Jacob John, who says it's possible that other viral diseases like dengue and other viral diseases that are endemic in places like India may have given the population some antibody protection against coronavirus. Others say that it's plausible that exposure to other milder coronaviruses could give some cross immunity, but clearly there's a lot more research that's required for all these things. There's also the issue is India actually counting all the fatalities? It says the problem is more acute in rural areas where 70% of the population live. Many rural deaths are not recorded unless the person has been in a hospital. And it goes on and on. It says, one physician says, quote, our poor routine death surveillance system misses many deaths in the first place. He reckons that only 1 in 5 deaths is recorded with a cause. So there's a lot of different possible explanations, maybe some combination of them, on why India's death rate has been so low. But the Times India did take a pretty good look at it, and you can read it and judge for yourself. And I imagine research will go on about this and why some countries got hit so much harder with fatalities than others. All right. Then I saw this report, which I suspect we're going to start seeing a lot of. And this is the first reported case of a person suffering from COVID-19 and H1N1 influenza. And it says Mexican authorities have reported the first case in the country of a person suffering from both COVID-19 and influenza A H1N1. It was a 54-year-old woman who had a lot of different situations, medical situations going on: autoimmune disease, chronic lung disease, cancer, and is overweight. I mean, not a lot was in the favor of this 54-year-old woman. The patient showed symptoms at the end of last month and was hospitalized, but they say she's stable, so we'll be happy about that. But seeing these co-infections with COVID, a respiratory disease primarily, and H1N1 and other influenzas, again, a respiratory disease, I think we're going to see a lot more of that as the flu season continues and marches forward. But I just thought that was an interesting report. That's the first time I've seen it. And apparently, according to the report, this is the first reported case. So that really brings me to this Harvard Health blog. And they put out some pretty good things from time to time. And they're encouraging flu shots. And it is that time of the year. And they say, wondering when you should get a flu shot? Well, they say the best time is before flu starts circulating widely. That's about September or October. And they say, why do we need to get a flu shot every year? And many people already know this, but I'll go ahead and repeat it. It's because the influenza and influenza A and B's, these strains mutate and they constantly change. Genetic mutations disguise them from the immune system. Prior exposure to one strain of flu will not necessarily protect you from other strains. So, organizations like the CDC are constantly monitoring the mutations and the changing strains around the world. And they use this data to develop vaccines months before flu season starts. However, a lot of times, a lot of these strains mutate by the time the flu season does start, and the vaccine loses some of its capability. Common strains of seasonal flu include H1N1 and H3N3. Now, how effective is the flu vaccine? Clearly not perfect. Never is perfect. Some years we see more or less dismal percentages of effectiveness, but on average it's about 40 to 60% effective in most years. And if you do get the flu, it's likely to be milder because the flu vaccine itself will reduce the risk of severe disease and death. During the 2018-2019 flu season, 35.5 million Americans got sick with the flu. More than 34,000 died from the flu. But the CDC says because of the flu shot, and about half of all Americans received the flu shot last year, they estimate that about 4.5 million cases, 58,000 hospitalizations, and 3,500 deaths were prevented because of the flu shot. They say that's equivalent to saving 10 lives per day during flu season. And there's also other benefits that go along with the flu shot, like reducing heart attacks and strokes and other conditions. So this is an important part, though, and this really goes along with the last article concerning the co-infection with H1N1 and COVID-19. Why is it especially important to get the flu shot this year? Measures that help protect us from COVID-19, such as distancing, wearing face coverings, and washing hands often, may also decrease the spread of the flu. Yet it's more important than ever to get vaccinated. The COVID-19 pandemic has caused shortages of hospital beds, ICU beds, and ventilators even outside of flu season. During flu season, when both the flu and COVID-19 will be circulating, hospitals, it's possible, may see shortages again and may affect their ability to care for people. And people can get COVID-19 and flu at the same time, as we just shown in the previous article. And the symptoms really overlap. A lot of non-specific symptoms, fever, chills, fatigue, body aches, coughs, can be found in both illnesses. So anyway, important recommendation, right? Important recommendation, you should get the flu shot. You should. And it's even more important this season due to this other virus that's circulating, this other respiratory virus that's circulating. All right, let's move on. Now, there's been a lot of debate about how long the SARS coronavirus 2 can survive on inanimate objects, right? If you can remember well enough, when this all started, there were people that were receiving their boxes from Amazon, and they were like wiping them down. They would let them sit in their garage for a couple days before they actually opened it. All kinds of stuff like that, because nobody really knew, the pathogenicity of COVID-19, and how long does this virus survive on objects? Well, in this research by an Australian organization called CSIRO, it's their national science agency, they say they found that the SARS coronavirus 2 can survive for up to 28 days on common surfaces that include banknotes, glass, and stainless steel. They also noticed that SARS coronavirus 2 survived longer at lower temperatures. It tended to survive longer on non-porous or smooth surfaces like glass, stainless steel, and vinyl, compared to porous complexes like cotton. And they survive longer on paper banknotes than plastic banknotes. And this was all published in the Virology Journal. And they say establishing how long the virus really remains viable on surfaces enables us to more accurately predict and mitigate its spread and do a better job of protecting our people. This is according to CSIRO Chief Executive Dr. Larry Marshall. Dr. Debbie Eagles, she's the Deputy Director of the Australian Centre for Disease Preparedness. She said, our results show that SARS coronavirus 2 can remain infectious on surfaces for long periods of time, reinforcing the need for good practices such as regular hand washing and cleaning surfaces. At 20 degrees C, which is about room temperature, we found that the virus was extremely robust, surviving for 28 days on smooth surfaces such as glass found on mobile phone screens and plastic banknotes. I assume that means credit cards. For context, similar experiments for influenza A have found that it survived on surfaces for 17 days. So they're saying this makes SARS coronavirus 2 more resilient than influenza A. The research involved drying virus in an artificial mucus on several surfaces at concentrations similar to those reported in samples from infected patients, and then re-isolating the virus over a month. Further experiments were carried out at 30 and 40 degrees C, with survival times decreasing as the temperature increased. And they also say that the study was also carried out in the dark, and this removed the effect of UV, which is pretty well known to inactivate the virus. While the precise role of surface transmission, the degree of surface contact, and the amount of virus required for infection is yet to be determined, establishing how long this virus remains viable on surfaces is critical for developing risk mitigation strategies in high contact areas. So, interesting stuff. Again, a lot of this was carried out in the dark, so, how important is that? You be the judge. But they are showing, at least in this one study, that the survivability of SARS coronavirus 2 is apparently quite lengthy. So I encourage you to check out this study. This is from, again, the CSIRO in Australia, if you want to take a look at that. And let me go ahead and close with this last story. This is out of the University of Toronto, and they say coronavirus antibodies last at least 3 months after infection. And it says coronavirus antibodies can last at least 3 months from after a person becomes infected with the virus that causes COVID-19, according to the study that was published in Science Immunology. Researchers from the University of Toronto and the Lunenfeld Tannenbaum Research Institute at Sinai Health used both saliva and blood samples from COVID-19 patients to measure and compare antibody levels for over 3 months post-symptom onset. They found that the antibodies of the IgG class that bind to the SARS coronavirus 2 spike protein are detectable for at least 115 days, representing the longest time interval measured. The study is also the first to show these antibodies can also be detected in saliva. According to Jennifer Gamerman, a professor of immunology at University of Toronto, says our study shows that IgG antibodies against the spike protein of the virus are relatively durable in both the blood and saliva. Our study suggests saliva may serve as an alternative for antibody testing. While saliva is not as sensitive as serum, it is easy to collect. Most people who recover from COVID-19 develop immune agents in their blood called antibodies that are specific to the virus. These antibodies are useful in indicating who has been infected, regardless of whether they had symptoms or not. Anyway, so that's interesting. There's another study that came out from, I want to say UMass, but I may be wrong, who had slightly different numbers, but they did determine that the SARS coronavirus antibodies did last for a period of time. And I could share that on another show. But anyway, so very interesting stuff coming out of the University of Toronto. This is something that a lot of people have wanted to know for a long time. I'm sure there's going to be subsequent studies on this because this is a big portion, right, of the herd immunity that we want to know about. And the fact that the antibodies can be found in more than the shortest term immunity is a good thing. So we got to like that. All right. Well, that's it. That's Outbreak News this week. I hope you enjoyed it. Please go ahead and subscribe to the channel, share it with your friends, comment below, and I'll see you next time.